So guys, this is continuation of our previous video that was about anatomy of furcation region, anatomy and anatomic variation of furcation region. Now we want to classify the furcation involvement. Why we talked about anatomy, I told you there are so many variations that can occur into the anatomic region that cause the problem with the cleaning, that cause the problem with treatment. But if we see a subject with periodontitis, we know that subject with periodontitis has bone resorption related problems. There can be a lot of bone related problems, and those can occur around the multi-rooted teeth as well as around the single-rooted teeth. But when it comes to the multi-rooted teeth, we said this region where the furcation is present means where the roots are separated from the trunk. This area is actually where the bone loss occur that causes trouble to the survival of the tooth. Okay, so to understand this, we really want to know that what is furcation invasion, what is its degree of invasion, which tooth is salvageable, which tooth is not salvageable, how we classify furcation, and how will we know that what is the diagnosis and prognosis of individual tooth based upon furcation. So let's understand what is furcation involvement. Furcation involvement means the furcation region is involved due to pathological loss, pathological reason, that is bacteria, due to accumulation of the calculus, due to accumulation of increased microbial load, and due to dysbiosis that leads to destruction of periodontal attachment and alveolar bone, particularly in this region of the bone, in this region of periodontal supporting structure. Means that the loss of pathological attachment loss that occurs into the furcation, bifurcation, or trifurcation region. Tri means where three different roots, three root separations are there, like tooth number 1/6 or tooth number 2/6 or 2/7 or 1/7, like maxillary molars. So when the problem exists in this particular region of furcation due to pathological breakdown, we are not saying this is anatomic breakdown, this is pathological breakdown that causes furcation involvement, means this region is involved, furcation region is involved, so that is called as furcation involvement. If we see clinically, we will be assessing this region via help of a probe. We'll talk about it, that is called as neighbor's probe. And if you see on an x-ray, we will find there is a loss of a bone and the radiolucency will be present into a particular region of furcation, and this loss will lead to appearance of radiolucent region on an x-ray. Similarly, if we see this tooth, it has no loss, so we cannot find any radiolucency in this particular region. But the tooth which is involved having furcation invasion has an interradicular bone loss is showing the radiolucent area. So it means this shows that there is a bone loss present. So first we need to diagnose the severity of furcation. How will we diagnose the severity clinically? Clinically, we see it via this probe that is called as neighbor's probe. And this neighbor's probe is having some markings present. And this neighbor's probe has markings. There are few markings present at 3 millimeter interval. If you see the first marking is 3 millimeter. The second marking is further added into it 3 millimeters, then further add 3 millimeters, and then further add 3 millimeters. So this way, the whole length of the probe is 12 millimeter. Every 3 millimeter has marking 3, 6, 9, and 12. So this probe helps us to clinically see whether the patient has furcation invasion or not, as this is the case. If you see, the probe is placed on the lingual side and it is nicely projecting from the buccal side. So it means there is a bone loss along with the tissue loss. That's why the probe is protruding outward. If there wouldn't have been a bone loss and there wouldn't have been a tissue loss, the probe cannot enter into this region. Okay, so we said there are different methods to see furcation region, and there are different ways that the bone is involved. The bone loss can be horizontal, the bone loss can be in a vertical direction, and the loss of the bone along with the soft tissue, which can expose the furcation clinically. Okay, so there are different ways to see the furcation. That's why the classifications are made to talk about this furcation region. Okay, so why do we classify the furcation defect? First, I need to diagnose what is the degree of invasion, what is the intensity that is present of the loss of the bone, or what is the intensity and severity of loss of interradicular bone present around the furcation region, number one. Number two, when I diagnose, then I would be able to treat the case. If I will not be able to diagnose, I will not be able to treat the case. Similarly, when I diagnose the case, I would be able to tell the prognosis to the patient that whether his tooth is salvageable or not, whether we can perform any procedure to save it or not. Means this is basically diagnosis is made upon some criteria, and that criteria we will talk about. So the diagnosis is based upon some criteria that is called as classification. We will be talking about classification later, but first we are actually understanding why these classifications are important. So these classification helps us to understand the case, the complexity of a lesion clinically, and to communicate with the patient, also communicate with the dentist in easy terms that whether we would be able to save the tooth, what will be the prognosis of the tooth, how long will the treatment take, what will be the cost of the treatment, what will be our treatment. Means we will be treating this case simply with non-surgical treatment or with a surgical treatment. We will talk about all these in details later, but just I want to give a overview that why is diagnosis essential. Okay, so we said that there are different means to diagnose this case via different classification system. There are several classifications that are given, but mainly we follow Glickman's classification, Hamp and Linde's classification, and Tarnow and Fletcher's classification. All the classifications are actually describing this furcation invasion, but they are considering different ways to diagnose the case. So if we talk about Glickman, it is basically a descriptive classification. This is subjective classification. This is not objective. So this is descriptive. It has no numerical value. It is only, telling the problem is there, but not in a proper numeric way. Whereas we come to Ham, it is objective classification. It objectively defines the problem via quantitative method, via some number. And it takes number 3 as a reference, 3 millimeter as a reference value. Now we come to the Tarnow and Fletcher. It also talk about the problem, the furcation invasion in number. Means again, it is quantitative, but the difference between these two is Hamp is talking about horizontal loss, and Tarnow and Fletcher, they are talking about vertical loss. So we said that there are 3 classifications: Glickman, Hamp, and Tarnow. The Hamp and Tarnow classification, they are quantitative and objective, whereas when we go to Glickman one, it is descriptive. So coming back to all these classification individually, that what they talk about. If we see Glickman classification, it is talking about furcation in 4 different grades, as grade 1, grade 2, grade 3, and grade 4. According to Glickman, there is a furcation invasion. Once it is grade 1, we say the lesion is very early. We cannot see it clinically. There is very little loss of interradicular bone, but it is largely intact. and there are no radiographic changes that occur in this particular case. And this Glickman's grade 1 classification or grade 1 is called incipient Furcation invasion, incipient Furcation involvement. It means our probe can clinically detect it a little, a notch like thing or a shallow depression can be felt, but there are no radiographic features present. There is no loss of soft tissue into Furcation region. So that's why this lesion is very early. I'm not talking about the treatment right now, we'll be talking about it later. So, according to him, the grade 2 invasion is little more deeper than grade 1. And he names it as cul-de-sac. Cul-de-sac means a sac having one end closed and one end open. So that's why he calls it cul-de-sac. It means there is a bone loss present, interradicular bone loss present. Our probe can enter nicely in, but if I put the probe from the buccal side, it does not comes out from the lingual side. There is some bone present that hinders the probe, though the probe is entering in easily, but there is intact bone present at some point that does not allow probe to enter till the full length of the interradicular bone. So that's why the probe does not pass through and through, and the lesion is deep and shallow, but broader than grade 1. And this is called as cul-de-sac, grade 2 Furcation invasion. When we come to grade 3, that is called as through and through. Through and through, it means when we put the probe in, the probe crosses whole the length of interradicular bone and comes out over the other side. Means if we are placing it from the buccal side, it comes from the lingual side. If we entering it from the lingual side, it comes from the buccal side. So there is complete loss of interradicular bone, but the soft tissue is still intact. There is no loss of the soft tissue. If this is the soft tissue, it is still there, but only there is interradicular bone loss. It means we cannot see this problem clinically because soft tissue is there. When the soft tissue collar is there, we cannot see it clinically. But if we see it on an X-ray, if we inspect it through probe clinically, our probe can enter in easily, and there is radiographic bone loss that actually tells us that there is a Furcation invasion. And this is called as through and through invasion of the interradicular bone, but with intact gingival margin. Now we come to 4, type 4 or grade 4 of Glickman. It says there is through and through invasion. Bone loss, interradicular bone loss is through and through, but along with soft tissue loss. When there is a soft tissue loss, it means I can easily see this case clinically. When patients come to me, I can easily see this Furcation invasion clinically with bone loss as well as soft tissue loss. So the main key difference between 3 and 4, grade 3 and 4 is soft tissue. That soft tissue recession is present in grade 4, whereas soft tissue recession is not present in grade 3. But if we see about interradicular bone loss, both have similar bone loss, that is complete loss of interradicular bone. That's why we call it through and through. So as I said, this is only descriptive type of classification given by Glickman. Hamp, Nyman, and Linde said that this is descriptive. We really don't understand that what is the depth of Furcation invasion in millimeter, and this is the Glickman's classification is subjective. It can vary. For example, if I do examination, it can vary. If you do examination, it will vary. So we need to have some objective classification with some proper measurement. So they said, and also they said like Glickman couldn't see proper, he couldn't define that how much probe in horizontal direction, how much penetration of the probe is in the horizontal direction. He said through and through, cul-de-sac, initial lesion and all. So they added few more things into it. They said, okay, we'll take the probe, and based upon those 3 millimeter marking of the probe, we take 3 as a reference value. And they divided basically this Furcation into degree. Whereas the Glickman talked about the furcation, but he was talking about the furcation in different way. He was grading at as grade. Grade 1, grade 2, grade 3, grade 4. And they are saying degree 1, degree 2, and degree 3. So according to them, if we put the probe in, and they're also looking for the horizontal loss, the probe is going this way. So there is interradicular bone present through all this passage. So they say that the degree 1 means there is less than 3 millimeter of the probe length going in. So there is less than 3 millimeter bone loss in a horizontal direction. It is called as degree 1. Degree 2, when there is more than 3 millimeter of the probe is entering in a horizontal direction, but not through and through. Not through and through, like as Glickman also said, not through and through in the case of grade 2. And degree 3, when the probe is entering in and whole length of the probe is somehow entering in, and probe when entered from one side comes from the other side in a horizontal direction, it means there is a complete horizontal bone loss, and this is called as through and through destruction as graded by Glickman as 3 and 4. Okay, so according to Glickman's 3 and 4, this is degree 3, and according to Glickman's degree 2, this Ham and Nyman and Linde's classification degree 2 is similar. But only difference is that Glickman couldn't talk about such penetration in number, whereas Ham, Glickman and Linde, Ham, Nyman and Linde, they are talking about this penetration in number. Okay, so I'm repeating again, 3 is taken as a reference. Degree 1 less than 3 mm invasion in horizontal direction. Degree 1 more than 3 mm in a horizontal direction but not in through and through. Degree 2 more than 3 mm, or rather don't use the term more than 3 mm, rather use it through and through, complete penetration of the probe in a horizontal direction. It is called as degree 3. Now comes another classification, that is Tarnow and Fletcher. They saw that Ham, Nyman and Linde, they talk about horizontal direction of invasion. But how about the vertical? There is also bone loss in a vertical direction occurring, and nobody talked about the vertical bone loss. So it's better to talk about the vertical bone loss at the same time into the interradicular region. So they add apicocoronal depth. According to them, not only horizontal bone loss present, but there is also presence of vertical bone loss. So they said that we will further classify this classification based upon the loss of the bone in millimeters. According to them, if there is 1 to 3 millimeter of the bone loss present in a vertical direction at the furcation region, they call it 1 as A. So this is vertical loss. If vertical loss is present in between 1 to 3 millimeter, they call it class A. And if the vertical loss is more, like 4 to 6 millimeter, they are naming it as class B. And if the vertical loss is more than 7 millimeter, they are naming it as advanced vertical extension or advanced loss as class 3. So Tarnow and Fletcher again added into the current classification, but they added the vertical component. Horizontal depth is already talked about Nyman, Linde, and in a descriptive terms from Glickman. But in vertical direction, if we see, it is further added as 1 to 3 millimeter loss as class A. 4 to 6 millimeter loss means moderate vertical extension of this lesion, class B, and more than 7 millimeters advanced lesion, class 3. They said if there is definitely there is a present of horizontal bone loss present. Assume according to Nyman classification, horizontal loss is B. We said Linde described in Linde, Nyman, and Ham, they classified the lesion as A, as 1, 2, and 3. If there is a degree 2 furcation invasion, as this is the case. If there is a degree 2 Furcation invasion present, we call it according to degree means horizontal. And if we want to add vertical component into it, then we'll be writing it this way. Class 2 means class 2 vertical component means loss of bone up till 6 millimeter. And B is talking about degree of invasion in a horizontal direction as talked about Ham, Linde, and Nyman. If, for example, if we say there is a degree class A classification or class A invasion, it means vertical component is being described. Class A with degree of invasion in a horizontal direction as 3. It means that class A is talking about vertical component, and this grade 3 or degree 3 is talking about the horizontal component. I hope I'm clear. I'm trying my best to explain it, but I hope I could explain this to you. So anyways, we said that there was limitation to Glickman classification. That's why we talked about Hamp and Linde talked about classification further into millimeters in a quantitative method. And similarly, if we talk about vertical component by Tarnow and Fletcher, they talked about again in millimeters, but in a vertical component. And they also said that study also said that few of these factors, they actually act on this clinical judgment of the classification, like the root trunk length, the divergence of the root. My first video is talking about it, furcation entrance width, bone loss, remaining bone, the mobility of the tooth, the plaque control factors, the smoking, the habits of the patient, and all these factors can again act on a defect. And they actually, for example, if our judgment is that we can treat the case, for example, if I say like the lesion is not through and through, but though the lesion is not through and through, but these factors, anatomic variation and these factors can act on my treatment decision. So I cannot wholly take the furcation as a key reference to treat, but I have to see other factors as well, the surrounding factors, the health related factors, the remaining bone related factors, the habits and everything, because they all collectively act on my treatment. So coming back to the story again in a nutshell, we said that the furcation defect can be described in a horizontal way, in a vertical way. In a horizontal, it was described by Hamp and his co-workers. In a vertical component was described by Tarnow and Fletcher as A to C. And also, not only these, and also the main classification was given by Glickman that was descriptive as grade 1 to 4. And we said that these furcation defects, only these classifications cannot help us to diagnose the case and tell about the treatment and prognosis of the case. There are also some anatomic and risk factors. They act on the treatment plan. The presence of these factors can also alter our treatment decision, can also, act on the decision of the treatment, can also act on the prognosis of the tooth. So they collectively shall be taken under view before beginning for any treatment of any case with furcation invasion. I hope I could possibly do it. Thank you so very much. If you like it, please share with your friends and please give your valuable comments to me. Thank you. Hope to see you soon. Bye-bye.